Okay, guys, so another important lecture, and already told you in the previous video that we will talk about the hyperthyroidism first, and obviously then the neoplastic changes in the thyroid. First of all, you need to know what is a hyperthyroidism. For that, let me tell you that a gland which is functioning in a basically the hyper functioning of the gland is called a hyperthyroidism, right? It means that more of the thyroxine is produced, more of the thyroid follicles are producing the thyroxine, and in turn the thyroxine is causing its effect, the peripheral effect, and the effects are not limited to one system. It's actually involving the whole of the system, like the cardiovascular system, the gastrointestinal system, and obviously the patient with a hyperthyroidism is going to present to you with heat intolerance, maybe the increased appetite, but despite of increased appetite, there is a history of a weight loss in such patients, and the patient may present to you with the heat intolerance as well, and maybe the patient will complain to you about the diarrhea, tremors, palpitation. The patient may have atrial fibrillation because whenever there is a sympathetic drive, thyroxine is actually stimulating the heart, contractility is increased, and as a result there is increased activity of the heart musculature, and in turn the patient can have atrial fibrillation, right? The patient may have hyperreflexia whenever you will stroke the tendon of particular muscles, there would be hyperreflexia. So to repeat all this, let me tell you once again that a hyperthyroid patient, what are the signs and the symptoms? Basically the patient will complain about the increased appetite, or weight loss, or heat intolerance, or maybe a history of shortness of breath, palpitation, diarrhea, and these are particularly the symptoms the patient will tell you. What are the signs you're looking for in a patient who is thyrotoxicosis, who is in thyrotoxicosis, or who is hyperthyroid? The signs are basically maybe particularly there's exophthalmos as in the Graves disease, or Graves ophthalmopathy, right? And the patient also can have increased reflexes, right? Maybe the hyperreflexia, there can be tremors, there can be atrial fibrillation. These are particular signs you're going to elicit in a patient who is coming to you with the symptoms of hyperthyroidism. Now the question is, what are the causes of hyperthyroidism? This is a very good picture. It will help you understanding and memorizing these things. There can be the inflammation of the thyroid gland. In some instances, there is when the gland is inflamed, actually what happens that some of the follicles are ruptured, and when some of the follicles are ruptured, the thyroxine is there's a rush of the thyroxine, and more of the thyroxine is released, and because of that there is increased activity of the gland, and the patient is hyperthyroid. But some instances, some of the inflammatory conditions, the patient can be hypothyroid, like in Hashimoto autoimmune thyroiditis or dequerent thyroiditis. But actually, as far as the follicle is intact, as far as there's no rupture, the patient would be hypothyroid. But whenever there is a rupture of the follicle and the thyroxine is released into the blood, then the patient will have the hyperthyrotoxic look, or maybe the patient will present to you with a hyperthyroid symptoms, right? What can be the other cause of the hyperthyroidism? There can be a single benign non-cancerous lump. I already told you, if you could appreciate the lecture I gave you previously, I told you there can be multiple nodules. There can be a multinodular goitre, or there can be a toxic nodule. So that single non-cancerous nodule, basically the heart nodule, that is actually the hyperthyroid, and the patient can have the symptoms of the hyperthyroidism. Rarely the pituitary gland produces too much of the TSH. Maybe there is a pituitary adenoma, and obviously what is the mechanism? Like the pituitary gland produces the TSH, that is the thyroid stimulating hormone, and the thyroid stimulating hormone then acts on the thyroid gland, and it actually increases the activity of the gland, and then more of the thyroxine is produced. So either there's a problem within the thyroid gland, or there's a problem high up level in the brain, like the pituitary, because there's more of the increase of the TSH levels. So that's why basically that overstimulates the thyroid gland, and that's why there is hyperthyroidism. Or there can be over medication of the thyroxine. Maybe a patient had a total thyroidectomy in the past, and now he's taking a thyroxine, or maybe there's iodine deficiency as well. So what happens whenever you're taking the thyroxine, and there's over medication of the thyroxine, the patient will have hyperthyroidism, right? So let me repeat all these things for you and make it very simple for you guys. Like, there can be the inflammation of the thyroid gland, already told you, and the inflammatory condition. The patient can present to you with a hyperthyroidism. The patient can present to you with a hypothyroidism as well. When the gland is ruptured, follicle is ruptured, obviously more of the thyroxine is released into the blood, and there is hyperthyroidism, single benign non-cancerous lump, which is called as a toxic nodule, and that can be hyperfunctioning. Rarely what happens that there's a pituitary adenoma, more of the TSH is released, and that stimulates the thyroid gland, and more of the thyroxine is produced from the follicles, and that goes into the blood, and obviously that will stimulate the different organ systems, and the patient will have hypothyroidism. Or there can be over medication of thyroxine. I hope this is a very simple diagram and it will help you guys understanding this. Moving to the other thing, which is basically the thyrotoxicosis, right? What is the difference between hyperthyroidism and thyrotoxicosis, right? Whenever there are different kind of signs, if the patient has tremors, the patient has atrial fibrillation, the patient has tachycardia, this is basically the thyroid storm, and T3, T4 levels are very much high, and the TSH in response is very low. So basically, this is a thyroid storm, and this is a medical and surgical emergency, right? So thyrotoxicosis, there can be diffuse toxic goitre, as in the Graves' disease. There can be toxic nodular goitre, or there can be a toxic nodule. I'll discuss all these things one by one. First of all, we're going to talk about the diffuse toxic goitre. Now, what is a diffuse toxic goitre like the Graves' disease? Graves' disease is basically the autoimmune disease in which there are antibodies produced. These are called the thyroid stimulating immunoglobulins. They're called the TSIs. Let me repeat. In Graves' disease, there's basically autoimmune disease, and TSI, thyroid stimulating immunoglobulins, or thyroid stimulating antibodies. They are produced and they act on the TSH receptors. And obviously, whenever they act on the TSH receptors, they stimulate them, and there's increase of the thyroxine. And as a result, there's more of the increase of the thyroxine, and the patient will have a thyrotoxicosis. So, and what is a toxic nodular goitre? Like, a patient have multiple nodules in nodules in the neck or in the thyroid gland, but one of the nodule is toxic, like it's hyper functioning, and it's producing a dramatically huge number of T3, T4 thyroxine. Then obviously thyroxine is the culprit here, right? And there can be a single toxic nodule. There can be multiple nodules, but only one of them can be toxic, or there can be a solitary nodule, but that solitary nodule is toxic, right? So these three things are very much important in thyrotoxicosis. There can be Graves' disease, which is basically the autoimmune disease. TSIs are produced, thyroid stimulating immunoglobulins. They act on the TSH receptors. And whenever they act on TSH receptors, there's a hyperfunctioning of the gland, and other entity is a toxic nodular goiter, and the other entity is toxic nodule, right? Or they can be hyperthyroidism to other causes as well. So this is basically a very good histological picture, which is showing you in the picture. You can see that this is the hyperfunctioning. There is increased cellularity, there is increased nuclear to cytoplasmic ratio, and you can see that there are large follicles which are basically there's a lot of the colloid stored in it, and obviously whenever the colloid is stored, that's producing more of the thyroxine, and that thyroxine is actually causing that thyrotoxicosis, right? And what is the treatment of thyrotoxicosis, right? For that, you need to understand, there was a picture I showed to you guys in the previous lecture. So what happens that we know that when the dietary iodine is taken up, actually, so that dietary iodine is transported through the sodium potassium iodide pump, and that pump actually then that iodine is converted into iodide, and that's the enzyme peroxidase, which is converting this iodine to iodide. And then obviously there's a coupling, and iodine actually couples up with the thyroglobulin and MIT mono amine iodine tyrosine and diiodotyrosine. They're produced, and then they combine together to form the T3 T4, which is basically triiodothyronine and tetraiodothyronine. So basically they're produced, and there's a proteolysis, and then T3 T4 that goes into the peripheral tissue. Mostly this is a T4, but the T4 is converted into T3 in the peripheral tissues, right? So this is the whole of the diagram. So this is the basic mechanism, that how the iodine is converted into this T3 T4 thyroxine, because iodine is the integral part of the thyroxine. So iodine actually is transported inside through the sodium potassium sodium iodide pump, and then obviously that pump is very, very important. And there's an enzyme inside the follicular cell. That enzyme is called as the peroxidase enzyme, and that converts that iodine into iodide. And until and unless the iodine is converted to iodide, there will be no formation of thyroxine. So this enzyme, which is called as a peroxidase enzyme, this is very much important. This is very much crucial. And obviously then there is a coupling, and then coupling will lead to the proteolysis, and then obviously T3 T4 is produced, and that goes into the peripheral tissues, right? So these are the thiamides, right? These thiamides actually, they block this enzyme. So whenever this enzyme is blocked, there will be no conversion of iodine to iodide, and when the first step is actually inhibited, all of the other steps will automatically be inhibited too, right? So obviously you give the patient who is in thyrotoxicosis, you give them thiamides, and then they actually block this enzyme, which is called as peroxidase enzyme, right? Or there can be iodides or thiamides, both of them, right? And they act on this step, which is basically they block the coupling, in which the iodide is actually combining up with the thyroglobulin. So basically either you block this step, which is the step 1, or you block this second step, which is the step 2, right? Thiamides actually inhibit the peroxidase, and thiamides and iodide, they actually inhibit the coupling. So either you block the conversion, or either you block the coupling. The net result would be, the consequences would be the same. There will be no T3 T4 production, and obviously there will be no thyroxine in the blood to cause the thyrotoxicosis, right? Or the iodides, they also act here, right? They also block basically the proteolysis. Actually MIT DIT, they combine with each other, and they form the T3 T4, and then there's a proteolysis, and the T3 T4 goes out of the follicle, and that goes into the blood, and then converted into peripheral tissues into T3. So either you block step 1, you block step 2, or you block step 3, right? Thiamides block step 1, it's a peroxidase inhibitor. Iodides and thiamides also inhibits the coupling step as well, and iodides are basically, they inhibit the proteolysis. So that's how the pharmacological therapies are helpful in the management of thyrotoxicosis, right? And there's another important thing, which is basically iodinated contrast media, or the beta blockers. What happens that in the peripheral tissue, the active form of the is a T3, which is basically the thyroxine, right? Which is basically the triiodothyronine. Thyroxine is produced in a huge number, but it's not active until and unless it goes converted into the T3, and which is basically the free T3. What happens that some of the T3 and T4, they're bound to with the globulins. So as far as they're bound to the globulins, they're not active, right? So actually the free form, free T3 and free T4, they are basically the active form, and they're the culprits, and they cause the thyrotoxicosis, right? So actually what happens that beta blockers, they you can say that they control or block the peripheral effects, right? So in the peripheral tissues, this conversion is inhibited, and there's no T3 to act on the peripheral tissues and produces thyrotoxicosis, right? So I hope so this slide was interesting, and it might help you understanding that. So let me tell you, there's a radioiodine which I have shown you in the previous slide, right here, because these are the iodides which are given to the patient in case of treatment for thyrotoxicosis. Now basically how the radioactive iodines they're working, actually what happens that you ask the patient, that is iodine 131, that is radio labeled, right? What do you mean by a contrast which is radio labeled? That means that that particular number, that isotope, is actually radioactive, and it emits some kind of radioactive waves which are then taken up by the tissue, whatever you want to see, right? So what happens that whenever you give a patient with a radioactive iodine, you ask the patient, you give them iodine 131 tablets, which are basically ingestible, and they're radioactively labeled, and then you give the radioactive iodine. This is ingested. Gamma probe actually measures the thyroid gland activity, and this is the scan. You can see there is increased uptake. You can appreciate in the diagram there are two figures, figure 1 and figure B. You can see there is a decreased density and there's increased density. Like you can see this black shadow, which is actually showing us that there is increased uptake of the radioactive iodine. That means that follicle or that nodule is actually hyperfunctioning. And hyperfunctioning, it is producing T3, T4, which are causing the peripheral effects. So that's how the radioactive iodine is helpful, basically, because these radioactively labeled substances, or the radioactive iodine is actually, this is taken up by the gland, and that's how you see it on the scan, right? So these were the pharmacological treatments. Now we're going to talk about some of the surgical options as well. But there is a term which is called as a pre-operative preparation before the thyroid surgery. This is very, very important, because before putting the patient on an operating table, you need to return back to the euthyroid state. Euthyroid state means that the patient has T3, T4 within the normal range, or TSH within the normal range, right? How we're going to do that? We're going to do that by using the pharmacological agents, and three important things: carbamazole, which is basically a thiamide. You can give either carbamazole or propyl thiouracil, which is called as PTU, right? You can have carbamazole, methimazole, or basically PTU, right? So carbamazole is 30 to 40 milligram per day, and whenever the patient returns to the euthyroid state, the dose is basically reduced to 5 milligrams 8 hourly. And preoperatively, you're gonna give the patient the beta blockers like propranolol, which is 40 milligram TDS, or longer acting nodule, which is basically 160 milligram once daily. Or you give the patient iodine in combination with the carbamazole, or in combination with the beta adrenergic blocking drug for 10 days before operation. So whatever happens, what I do is whenever a patient is coming to me with the thyrotoxicosis, and he has a big diffuse multinodular goitre right in front of the neck, and I'm suspecting that it is a toxic multinodular goitre. So, and obviously the patient needs surgery, the patient needs total thyroidectomy. But first of all, what I need to do is I need to put up the patient in a euthyroid state from a thyrotoxic state, right? So I will put up the patient for a week or 10 days on a pre-surgical or pre-operative medications. I already told you, carbamazole, beta blockers, or maybe iodine, right, in combination with a carbamazole or beta blocker. So the dose for carbamazole is 30 to 40 milligram per day, and whenever the patient is euthyroid, reduce the dose to 5 milligram, right? And you also give the beta blockers. Why beta blockers? Because actually they are actually the receptor blockers. They're acting on the peripheral tissues, and they're actually blocking the effect of thyroxine on the peripheral tissues. So beta blockers are very important as well. You can give propranolol 40 milligram TEDS, or you can also give the longer acting nodular, which is 160 milligram once daily. And you can also combine iodine with the carbamazole or beta adrenergic blocking drug. This whole of the preparation should be done at least a week before or 10 days before this operation. Now the question is, you guys might think why this is important. Because whenever you are putting up a thyrotoxic patient on an operation table, you're actually risking his life. Why? Because obviously when you're going to open up the thyroxine, there would be a thyroxine rush. The patient will have thyrotoxicosis, and that would be the thyroid storm, and the patient will have atrial fibrillation, and the patient can collapse. So that's why this is very, very important. Wherever you do, that's as a logic. Whatever I do, that there is a logic behind everything we do. So the logic is basically, before putting the patient on operating table, you need to return the patient to a euthyroid state, so that the patient should not be in a thyroid storm, or patient should not go to the atrial fibrillation, and the patient should not collapse, right? So these are the preoperative measurements, or the preoperative steps you have to perform, or the preoperative preparation you have to do before the thyrotoxic surgery, right? Now, this is very important. I already discussed the three modalities which are basically important. You can either go for the total thyroidectomy, you can either perform near total thyroidectomy, or you can go for near total, or you can also say call this a subtotal thyroidectomy, or you can go for lobectomy, right? But if there's a diffuse multinodular goiter, right, like the patient has a grave disease. Let's suppose the patient has a grave disease and the patient is thyrotoxic as well. What you have to do is, first initially you have to do the pre-op preparation, you have to return him to a euthyroid state, and then you're going to perform the surgery. But actually, what is a surgical option in case of grave disease? The surgical option is total thyroidectomy. We do not perform subtotal or near total thyroidectomy or lobectomy in a patient who's actually coming up with a multinodular goiter or the grave disease, right? And the thing which is very much important before the surgery, you can also put the patient on radioactive iodine ablation therapy, and obviously 75% of the ablation therapy is given initially, and the 25% is given after that. So initially the bolus, like the 75%, you give the initial dose of the radioactive iodine, and there's ablation of the gland with the radioactive iodine as well. And the response is usually that comes up between 6 to 12 weeks, and the remaining 25% of the dose is given just after 6 to 12 weeks, right? And now the question is, what are the techniques, right? You can either perform the open thyroidectomy, you can go for the endoscopic thyroidectomy, or you can actually perform the robotic thyroidectomy. The robotic thyroidectomy and the other thing which we call as laser thyroidectomy, these are the new surgical modalities. First we're going to talk about the open thyroidectomy, and then we're going to talk about the laser, and then we're going to talk about endoscopic, and we're going to talk about robotic thyroidectomy, right? The picture, this is basically a midline incision given just in front of the neck, and the neck is exposed, and obviously some books say that is 4 to 5 centimeter of the incision, and some expert surgeon, they give a 3 centimeter incision just in front of the neck to open up the thyroid gland, because the thyroid is actually just in front of the trachea, and it's basically the isthmus is just in front of C2 and C3 cartilages of the trachea, right? So what happens, this is a picture of the open thyroidectomy. So you give a midline incision, a transverse incision just in the middle of the neck, and the incision is about 5 centimeters. So it can range from 3 to 5 centimeter, right? You perform the open thyroidectomy, the neck is exposed, the fascia is separated, you go deep inside, you identify the vessels, and you identify the trachea. Isthmus is just in front of the trachea. You identify the lobes, and you perform the total thyroidectomy. And again, then the incision is closed and layers, and obviously, but you have to take care of two important things. First, you have to ligate the thyroid arteries, the superior thyroid artery, the inferior thyroid artery, and you have to also take care of the recurrent laryngeal nerve, because this nerve is very, very important, because it's just passing in front of the groove between trachea and esophagus, right? And this is very much important, so you need to avoid that injury as well. The other technique is basically this was the picture I was talking about. Actually, this is thyroid, and these are the arteries. So you ligate the arteries first. You ligate the superior thyroid. You ligate the inferior thyroid. You'll actually localize or you'll identify the recurrent laryngeal nerve. You will secure the recurrent laryngeal nerve, and then you will take out the whole of the gland, total thyroidectomy or subtotal or lobectomy, whatever you have decided for your patient. But you have to take care of two things. The arterial supply should be occluded first, and then you have to secure recurrent laryngeal nerve as well, right? And then there's another technology, which is basically the newest technology. Initially, till today, in some of the countries, what happens is we perform open thyroidectomy because it's very easy. Neck is a very close compartment, the triangles, and the most of the important vessels are lying. Obviously, the carotids, the trachea, the esophagus, all of the important structures are in the anterior triangle and the lateral triangles, respectively. But so obviously people are more secure, or they feel more comfortable to perform the open thyroidectomy. But newer techniques include the endoscopic thyroidectomy. It's actually a camera or the endoscope, actually 3 centimeter transverse incision. You can see here a 3 centimeter transverse incision is given. This is the endoscope. You put the camera from that incision, and you actually visualize everything. This that's kind of a graph or a picture that comes in front of you. You visualize everything, and obviously you can see there's a 3D camera, and you can see the structures in a very good position, and you can decide like whether you will identify the vessels, nerves. So these are basically, because the image is magnified, so that helps you very much. So this is a new technology. But there is another technology which actually they call as robotic thyroidectomy. Endoscopic thyroidectomy is different, and a robotic thyroidectomy is different. Most of the countries, it's open thyroidectomy, but some also perform the endoscopic thyroidectomy. But in most advanced, robotic thyroidectomy is performed. What is the difference between the endoscopic and robotic thyroidectomy? Actually, an endoscopic, you put the endoscope and you give a transverse incision in neck, but the scar is like maybe 2 or 3 centimeter. So actually, endoscopic surgeries are more preferable to open, because there's a little scar, there's a good healing, and obviously that's good. But robotic, actually there's no scar on the neck, because actually what you do is you put the endoscope, or actually you can say that there are 4 robotic hands, and there's a 3D camera as well. So what you do is you put the 4 robotic hands through the axilla, and it's a big incision, maybe a 5 to 7 centimeter incision, but the approach is from the axilla, maybe the left or maybe the right, it's up to you. So but you go actually from the axilla, and then you actually find a way, and you visualize everything on the 3D camera, and you identify, and there's no scar on the neck. So these are the surgical options: open thyroidectomy, whatever you want to do, lobectomy, total thyroidectomy, or subtotal thyroidectomy, whatever you perform. There's an open entity, there's an endoscopic entity modality, or there's also robotic surgery, which is very much common in South Korea, because it was initially given up by the South Korean doctors. So basically now some of the advanced countries, they're also using this robotic thyroidectomy, but it needs high level of expertise, because actually you have to handle they're very minute little instruments, which are the robotic instruments. So they're very, you grasp the arteries and everything with those robotic hands, but to handle them, you need to have very good actual expertise, and the handling should be very nice and precise. And you look on the 3D camera, the vision is good, and everything it's just like if you take an ultrasound guided biopsy. So it's just, you can say that as actually a camera guided scopic surgery, which is basically you are performing, right? So now the question is, what are the advantages? Like, why don't all the people go for the open thyroidectomies? Why some perform the endoscopic surgeries, and why some of them perform the robotic? Because neck is actually a very exposed area, and people are very cosmetically, they're very much concerned about the scar. Because if it's a big scar, 4 to 5 centimeter, just in front of the neck, obviously it doesn't look nice and it looks odd. So for the cosmetic reasons, we give an incision 3 to 4 centimeter, and we do it by endoscopic. And obviously when the wound is, or the incision is small, it is actually healed more easily and more quickly. So in order to avoid the wound infection, or that's why the incision is small and healing is rapid, we perform the endoscopic surgeries. But what is advantages of the robotic surgery over the endoscopic surgery? The advantage is that there's no scar on the neck. You just go from the axilla, and obviously axilla is not the exposed area. You go from the axilla, you give a deeper incision, 5 to 10 centimeters, but you go into the neck from the axilla, and there's no scar on the neck. So that's how it's very, very important. So these are the newer technologies. They're not practiced everywhere because of resources, or maybe because of expertise, but actually they are into the market. And whenever you achieve expertise, you can always go for the laser, you can always go for the endoscopic surgeries, or you can also go for the robotic surgeries as well. So these are basically the different treatment options you can always perform in your patient. But the newer technology is basically the robotic thyroidectomy, the robotic surgeries. And this is most common in South Korean because this technology was initially founded by them and given to the world by South Korean people. So guys, we're going to talk about the post-operative complications as well. The first post-operative complication in a patient with a thyroid surgery can be hemorrhage. Because obviously you're dealing up with the major vessels in the root of the neck. You're dealing up with the superior thyroid. You're dealing up with the inferior thyroid arteries. So if you don't ligate those arteries properly, you can injure some of the vessels in the neck, in the anterior neck, and there can be a hemorrhage. And the patient later on, if you don't put a drain while performing the surgery, the patient can later present to you with a hematoma. So hemorrhage is the first post-operative complication. The patient can have a parathyroid insufficiency. Why? Because on the posterior surface, there are 2 superior and 2 inferior parathyroid glands, and actually these parathyroid glands are taken off along with the thyroid gland, especially when the total thyroidectomy is performed. So there can be parathyroid insufficiency. You have to put the patient on a lifelong parathyroid hormone, or along with the thyroxine. So if you don't put your patient on a parathyroid treatment or the parathyroid hormone replacement, so whatever, you don't give the patient calcium and the multivitamins along with the thyroxine, what happens is like the patient will have a parathyroid insufficiency. There can be thyrotoxic crisis. There can be stitch granuloma, because whenever you're stitching the layers, and when you're stitching the skin, you take along with some of the granulation tissue, and that granulation tissue you can appreciate in this picture that this is actually, whenever you take the stitch in the skin, you take that granulation tissue along with you, and later on that produces the stitch granuloma, right? And obviously there can be wound infection if the wound is large, and the patient, especially it's very much common in the diabetic people. Why? Because the diabetics, they don't have a good glycemic control, and their wound healing is very much delayed, or so those who are basically immunocompromised, there is more of the tendency of the wound infection in such patients. There can be thyroid insufficiency, because already told you, if you perform total thyroidectomy, and you don't put a patient on a thyroxine replacement therapy or thyroid replacement therapy, the patient can develop the thyroid insufficiency. There can be hypertrophic or keloid scar after the incision, and this is very much common. There can be hypertrophic or keloid scar. There can be recurrent laryngeal nerve paralysis. If there is a unilateral recurrent laryngeal nerve paralysis, there will be hoarseness, and if there's a bilateral recurrent laryngeal nerve paralysis, the patient will have shortness of breath and severe respiratory distress, right? Now coming to another important topic, which is basically the classification of the thyroid neoplasms, right? Initially, you divide these into benign and the malignant categories. The benign includes the follicular adenoma, and malignant, they include the primary, which are basically the follicular epithelium differentiated, like the follicular papillary, and there is a follicular epithelium coming up from the follicular epithelium, but they're not differentiated, they're poorly differentiated, and they're anaplastic. Or you can call them undifferentiated, right? And there can be some of the tumors, primary tumors or primary malignant category neoplasms, which are basically arising from the parafollicular cells, and they're called as medullary carcinoma of thyroid, or there can be some of the tumors which are arising from the lymphoid cells, right? Which is basically the lymphoma, or there can be secondary like the metastatic local infiltration, right? So this slide is very much important, and I'll discuss this one by one in detail. First of all, we'll talk about the benign, and then we're going to talk about the malignant neoplasms. Benign are actually, what is the differentiation between a benign and a malignant category, right? Benign is like which is limited, which is a very local spread. Benign is actually a capsule, and it's limited, and it's not metastatic, and it's not aggressive as well. So benign includes the follicular adenomas, and whenever these adenomas are taken up, they have a very, very, very good prognosis. There's another category, which is basically the malignant, and there's increased nuclear to cytoplasmic ratio. There's no capsule, they either locally invade, or there's a lymphogenous basically, or hematogenous spread of the tumor along with the local invasion. So we divide the malignant into primary and secondary categories. Primary are basically those which are derived from the follicular epithelium, and they're basically, if they're differentiated, they're follicular and papillary. And let me tell you, these are the most common tumors of the thyroid. So the most common tumors of the thyroid are follicular and the papillary, which are arising from the follicular epithelium, and they're differentiated. And there's another category which is also derived from the follicular epithelium, but they are poorly differentiated, and they're called as anaplastic. Why they're called anaplastic? Because there is arbitrary shape. There are cells of the different shapes, and they have different nuclear to cytoplasmic ratio, so they're called as anaplastic cells. And basically, the thyroid has parafollicular C cells, which are producing the calcitonin, which is very much important. Basically, that's the inhibitor to the parathyroid hormone. So what happens is, in case of these tumors which are arising from the parafollicular cells, they're called as a medullary carcinoma of thyroid. And there's another entity which is called as a lymphoid cells, which are called as lymphoma, or they can be secondary metastatic local infiltration, right? Now, the most common tumors are follicular and papillary carcinomas. Anaplastic, they are very aggressive, they're very poor, and they're very, very much poor prognostic factors. Medullary carcinomas are basically, they can be solitary medullary carcinomas, but they can be genetic, a part of the MEN syndrome, MEN2A or MEN2B syndrome, and they can be lymphoma. So these follicular and papillary carcinomas, but the question is how you will differentiate a follicular adenoma from the follicular carcinoma, because the follicular adenomas, they don't have a vascular invasion, but the follicular carcinomas, they have a vascular invasion, right? So when you are histologically viewing these cells, what you have to look for, the vascular invasion. If there's a vascular invasion, this is a follicular vascular carcinoma. If there's no vascular invasion, this is a follicular adenoma, right? So benign tumor, this is basically a benign adenoma. You can appreciate in the picture. You perform the lobectomy in such cases because they're not harming. They have no metastatic or local invasion, and their prognosis is very good in case of the benign tumors, right? If you talk about the malignant tumors, this is a big malignant tumor right here, and this malignant tumor is actually invading. These are also important, right? But malignant tumors, this is a picture of the malignant tumor. You can see that it's almost 5 centimeter, and actually the whole of the gland is taken up. But these are the malignant tumors, which are 2 of the nodules. They are malignant in nature. You can appreciate this is abnormal and this normal, and the whole of the thyroid gland is taken off. So if you talk about the papillary carcinoma, this is the papillary carcinoma, and you can see there is increased nuclear to cytoplasmic ratio, and they are invading into the vessel. There's a vessel lining up here, and these are basically the papillary cells. These are actually derived from the follicular epithelium, and they're very differentiated, and papillary and follicular carcinomas are very much common. But papillary carcinomas, they have association with the childhood radiation. If a child comes to you, or if an adult comes to you with a thyroid swelling, and further you do the investigation and you found out that there's a papillary carcinoma, what you need to ask the patient, you need to ask for the radiation therapy in the childhood, right? There's a possibility, 99% possibility, that the patient had radiation therapy in the childhood, and later on he developed a papillary carcinoma. So these are the things you have to ask the patient. Follicular carcinoma, here you can appreciate there's a large follicular carcinoma which is compressing the trachea behind, because the tumor is just in front of the trachea, right? And medullary carcinomas, these are small, tiny, cute parafollicular cells, but you can see here their nuclear to cytoplasmic ratio is increased. So actually they're not very common like the papillary or the follicular carcinomas of the thyroid. They're less common, and they're rising from the parafollicular C cells of the thyroid gland actually, and they're producing the calcitonin. Either if there's a solitary thyroid tumor, what are we gonna do? We will take out, you can perform the lobectomy. But if you do the whole of the genetic studies, and you find out that this is actually MEN syndrome, either 2A or 2B. So what you do is you take off the whole of the tumor out, you perform the total thyroidectomy, right? In case of solitary medullary carcinomas, you can perform lobectomy, but in case of medullary carcinomas, which are a part of MEN syndromes 2A or 2B, you perform the total thyroidectomy, right? Malignant lymphoma, there can be basically lymphoma is how you define lymphoma. Lymphoma is basically the origin is from the premature lymphocytes, and obviously it can involve the thyroid gland as well, right? You can appreciate in the picture, this is a lymphoma right here, just present here, right? And this is a picture you can appreciate here. Now, what are the treatment options for the neoplastic tumors, malignant basically? That depends upon 4 things, right? Preoperative finding, surgical procedure, post-operating finding risk, and we'll talk about the indications of radioactive iodine therapy as well, right? If a patient is coming to you and there is a suspicion malignant thyroid nodule, what you do is, if the tumor is less than 1 centimeter, you perform lobectomy, and the postoperative risk is low, that is T1A, and there's no indication of radioactive iodine therapy. If the tumor is greater than 1 centimeter, but less than 4 centimeter, and there is no evidence of lymph node metastasis, you perform the total thyroidectomy. Or they can be low risk, and if this is low risk and T1B, T2, FTC with no or minimal vascular invasion, you don't actually perform the radioactive iodine therapy. But in case of intermediate, if it's T3 or N1A, N1B, it's actually basically you consider for the radioactive iodine therapy as well, right? And if the tumor is greater than 4 centimeters and there's evidence of lymph node metastasis or distant metastasis, you go for the total thyroidectomy with lymph node dissection. And there is a high risk post-operatively, T4, M1, FTC, you with extensive vascular invasion, and obviously you will perform the radioactive iodine therapy. This picture or this flow sheet is very much important to you guys, because the tumor size, the invasion, these are very much important to actually decide what kind of surgery you're going to perform, and then after the surgery, whether you put the patient on the radioactive ablation iodine therapy or not. So if the tumor size is less than 1 centimeter, you perform the lobectomy, and the post-operative risk is low, that is T1A, and you don't go for the radioactive ablation iodine therapy. If the tumor is greater than 1 centimeter, but it's less than 4 centimeter, and there's no evidence of lymph node metastasis, you perform the total thyroidectomy. If there is a low risk or there's an intermediate risk. If there's a low risk with no or minimal vascular invasion, you do not go for the radioactive iodine therapy. But in case of intermediate, T3, N1A, N1B, you consider for the radioactive iodine therapy. But if a tumor is greater than 4 centimeter and there's evidence of lymph node metastasis or distant metastasis, you perform the total thyroidectomy with lymph node dissection, and there's a high risk post-operatively, T4, M1, FTC with extensive vascular invasion, and you go for the radioactive iodine therapy. All right? What are the surgical options? Already told you, you perform the thyroid lobectomy, subtotal thyroidectomy, or thyroidectomy. It depends upon the tumor size. If the tumor is less than 1 centimeter, you can go for lobectomy. If it's an extensive tumor, you have to perform the total thyroidectomy. But you don't have to perform the lymph node dissection if the tumor has basically the intermediate risk or low risk. But if it's a high risk carcinoma and you perform, and the tumor size is greater than 4 centimeters and there's distant metastasis with extensive vascular invasion, you perform the surgery. But after the surgery, you also put the patient on the radioactive ablation iodine therapy. So this was all about the whole of the lecture, and I hope I was successful in making you understand the whole of the things. And thank you for watching sqadia.com. We'll meet in the next lecture. Till then, bye bye.